Bismillah ar-Rahman ar-Rahim. Today we will speak about common dislocations. We have to define what is the meaning of dislocation. Dislocation is complete loss of contact between the two bones forming the joint with disruption of its ligamentous supporting structure. If associated with fracture, it is called fracture dislocation. Subluxation is a partial loss of contact between the two bones forming the joint. If associated with fracture, it is called fracture subluxation. Dislocation can occur at any joint in the body, but the most common is dislocation hip, dislocation shoulder, dislocation elbow, dislocation knee, and dislocation ankle, which is usually associated with fracture. That's why it is called fracture dislocation. First, we have to start with dislocation hip. We can classify dislocation hip according to number 1, the cause, number 2, according to the direction of displacement of the distal fragment, which is the head. If we classify dislocation hip according to the cause, we have congenital dislocation hip, traumatic dislocation, which is the subject of today, pathological dislocation, and paralytic dislocation. If we classify dislocation hip according to the position taken by the dislocated head, we have posterior dislocation, which is the commonest, anterior dislocation, which is less common, and central dislocation, which is usually associated with fracture of the floor of the acetabulum. That's why it is always called central fracture dislocation. As we see, number 1 is the posterior dislocation, number 2 is the anterior dislocation, number 3 is the central fracture dislocation. We have to start with posterior dislocation hip. The hip joint is the strongest and the most stable joint in the body. For this strong, very stable joint to be dislocated, we must have number 1, severe trauma, number 2, the hip must be in its weakest position, which is flexion, adduction, and internal rotation. To understand this, in the neutral position, the hip is in its strongest position because it is completely covered and surrounded by the acetabulum. But when the hip is flexed, adducted, and internally rotated, the hip is not covered now by the acetabulum, and it is very weak. It is in its weakest position, and any trauma can dislocate it posterior. To diagnose posterior dislocation, on examination, the patient comes to us supine with the hip flexed, adducted, and internally rotated. If any patient represent to us with supine, with the hip flexed, adducted, and internally rotated, giving history of severe trauma, we have to suspect posterior dislocation hip till proved otherwise by the X-ray. As we see, the patient is supine with the hip flexed, adducted, and internally rotated. And if we observe that the medial malleolus of the sound limb is present at a lower level than the medial malleolus of the affected hip, this means that shortening of the affected hip. that is the second clinical picture, is shortening. The hip is swollen, tender, and sometimes with ecchymosis, absolute painful limitation of all movements in all directions, shortening as mentioned before. The head is not felt in its normal position as indicated by absence of the femoral pulse, which is called vascular sign. What is the meaning of this? Normally, any pulse is felt against the bone. That's to say, the radial pulse is felt against the radius. The femoral pulse is felt against the femoral head and the neck. But if the femoral head and the neck is displaced from its position, we cannot feel the femoral pulse, indicating that the head is dislocated, and that's called vascular sign as mentioned before. The head is felt in the gluteal region as a hard bony mass. We have also to search for the presence or absence of complications, especially sciatic nerve pulse, indicated by drop foot. Why? For medico-legal importance, number one. Number two, to discover complication early and to treat early to gain better results. Number three, to protect yourself. Radiological examination. CT will be done if we suspect the presence of entrapped intra-articular fragment. This plain X-ray showing dislocated hip in the right side and the left side is sound or normal. We have to search for 6 finds in the X-ray and to compare both hips together, the sound and the affected hip. In the right side, the head is not present in its normal position. That's to say, it is not present inside the acetylum, compared to the opposite side in which the head is present inside the acetylum. This means dislocation hip in the right side. Number two, in the right side, the lesser trochanter disappears due to the presence of internal rotation. Compared to the opposite side, the lesser trochanter is well marketed and is well seen. Shenton's line is disturbed, Simon's line is disturbed, and we have to search for the presence of associated fracture and the presence of entrapped intra-articular acetabular fracture. What is the meaning of Shenton's line? Shenton's line is the line drawn from the lower border of the inferior, from the lower border of the neck and the lower border of the superior pubic ramus. These two areas represent together one continuous uninterrupted arch as seen in the left side. But in posterior dislocation hip, if we draw a line extending from the lower border of the superior pubic ramus, it will not form a continuous line with the line drawn along the lower border of the neck. This means that in the right side the Shenton's line is disturbed, while in the left side the Shenton's line is continuous, uninterrupted arch and not disturbed. Simon's line. Simon's line is formed from the outer border of the iliac bone and the upper border of the neck. The upper border of the neck, together with the outer border of the superior of the iliac bone, form together one continuous uninterrupted arch. But in dislocation, the line drawn along the outer border of the iliac bone and the line drawn in the upper border of the neck are not continuous, are not in contact with each other. This means that interruption of Simon's line or disturbance of Simon's line, and that is a radiological sign of posterior dislocation of the hip. Another example of posterior dislocation hip. If we come to the complications of dislocation hip, posterior dislocation hip, we have to first to start with complications that endanger the patient limb, especially the neurovascular injury or the neurovascular complications. The most important neurovascular complications in posterior dislocation hip is the sciatic nerve palsy, as indicated by drop 2. Then the second and third and fourth complications of posterior dislocation hip are related to the reduction. Number 2 is unstable dislocation, means that when I reduce the dislocation, it recurs again immediately after I lift the patient. Then number 3, irreducible dislocation, means I cannot reduce the dislocation because of some obstacle in the acetabulum, as the presence of entrapped intra-articular fragment. The fourth one is unreduced or neglected dislocation. Reduced or neglected dislocations means the patient represents to the doctor after the passage of several days or sometimes a month. It is difficult to be dislocated, it is difficult to reduce it conservative, but it must be operated upon. Number 5 is a vascular necrosis of the head, osteoarthritis, stiffness, and myositis ossificans. Treatment of posterior dislocation hip, either by closed reduction or by open reduction. That's the picture of closed reduction. Anterior dislocation hip, the same in everything as in posterior dislocation, except the trauma occurs while the hip is abducted, flexed, and externally rotated, and the patient is supine with the hip abducted, flexed, and externally rotated. That's how anterior dislocation occurs, by severe trauma with the hip abducted, flexed, and externally rotated, as shown in this picture. The patient comes to us with the hip supine, with the hip flexed, abducted, and externally rotated, of course with some shortening of the affected limb. That is how to reduce anterior dislocation of the hip. That is the central fracture dislocation. Another example of central fracture dislocation. We have to speak about dislocation shoulder, caused by fallen out stretched hand, classified as examples, as anterior. How to diagnose dislocation shoulder? On examination, nearly the patient comes to us as in this picture, the acromion is prominent, the shoulder is flat because of dislocation, or because the head of the humerus is not present in its position. The humeral head is prominent anteriorly, the arm is slightly abducted, the elbow is flexed, the forearm is pronated and is supported by the other limb. That is example of complication of dislocation shoulder. We have to go specificants. That's how to reduce anterior dislocation. Dislocation elbow caused by fall on outstretched hand. It also classified according to the direction taken. To diagnose dislocation elbow, we have to start on examination, ecchymosis and tenderness, loss of the triangle. That's example of dislocation. Another example of dislocation elbow, the acromion goes. Complication going through. That's how to reduce dislocation elbow. Dislocation knee. We have anterior dislocation, we have posterior dislocation. That's example of anterior dislocation. The most important complication in dislocation knee is the neurovascular complication because of the proximity of the popliteal artery behind the knee. The popliteal artery may be injured, and we have to search for the presence or absence of ischemia by feeling the dorsalis pedis pulse. Also, other complications can occur, especially injury of the ligament of the ligaments of the knee, as medial ligament, lateral ligament, anterior cruciate and posterior cruciate, or also injury of the menisci. Also, compartmental syndrome can occur, and other complications exactly the same as in posterior dislocation, as stiffness, myositis ossificans, and arthritis. Thank you and good luck.